speak about rotator repair, and let's see a little bit how this works. And first of all, I want to say thank you for the preparation of this webinar that we made, and Usama who organized this, and Saeed who kindly accepted to participate, to co-participate with me to this one. Thank you very much. So now just a little look to Annecy. This is the view from Annecy, the lake of Annecy, and she is close to Geneva. It's east part of France for people who don't know. And here, if you look at this little circle here, what you can see is my hospital. It's a very old hospital. It started from the very beginning. It was just 2 operating room and 2 office, and with a waiting room. And you can see now it was rebuilt all around, and there's a lot of things all around that we can arrange now. And this is the private hospital. These are my disclosure that you can find on the website of the AAOS, find easily here. And now we go to the topic. We have today discussion about rotator cuff, and we can see here the posterior superior rotator cuff and the subscap. The main issue, by understanding rotator cuff tear, is to really separate subscap with anterior entity totally different to the posterior superior entity, taking into account that subscap is pulling the shoulder posteriorly because the scapula is posterior to the thorax. And this is very, very important to understand. The normal cuff is here, and we used to say the anterior cuff is something which is at the anterior side of the shoulder. Wrong. The anterior side of the shoulder is posterior to the thorax, and the scapula is posterior to the thorax. So what happened is that if you have like now an anterior cuff tear, and then you will have an anterior superior migration of the humeral head because this muscle is not pulled back posteriorly anymore. Usama, I don't know about you, but I can hear some noise on the background. Maybe somebody did not disconnect the microphone, or there's some noise. I don't know.
Okay.
This is the posterior cuff tear, which is different. The migration is posterior, and this is the massive cuff tear, where the migration, in case of contraction of the deltoid, will be an upper migration of the humeral head, and there is nothing that will center the humeral head anymore. So that's the problem of the rotator cuff. The duty of the subscap is to stabilize the shoulder, and it's a very big muscle. It has 2 parts. Mostly, we know it's close to 7 parts, but the 2/3 upper tendon are different to the 1/3 inferior, which is more muscle, and a capsule, which is very thick capsule, but very thin muscle attachment here. What is important to understand is that the muscle, the tendon, if you look at the really intra-articular arthroscopic view, looking from posterior, it's very difficult to assess the entire subscap. And if you only look at the intra-articular subscap, what you can see is the upper 1/3 of the subscap, because all the lower 2/3 of the subscap are covered by a capsule, which makes that the subscap repair was much later managed arthroscopically than the posterior superior rotator cuff. So now, if we go to the intra-articular view, this is what we can see. And here you see it's an intra-articular with air. It's a very old video, but what you see is that subscap is part of the anterior stabilization of the biceps. And there is a relationship between the biceps and the subscap attachment, which is very high. And this is linked to the proximity. But let me tell you that in a few cases, we can have a subscap tear with no biceps instability, which is extremely rare. But what I'm saying here is that the entity of the stabilization of the biceps is really linked to the ligament, superior glenohumeral ligament, and the coracohumeral ligament anteriorly. Posteriorly, the biceps is close to the supraspinatus and stable. What you can see here is that the subscap is even crossing the medial glenohumeral ligament, and this cross means that when you have a retraction of the subscap after a tear, and then it gets stuck to the ligament, and it's very important to release the subscap from the ligament when you want to repair the subscap and bring it back to its normal position. And at least what you can see is that there is a very thin capsule at the upper part of the subscap, which is the rotator interval. And this rotator interval is something which you can open and access to communicate from the inside to the outside of the shoulder. What is very specific to the subscap too is the nerve, the vascularization and the innervation of the subscap is totally different to the supra and infraspinatus. Supra and infraspinatus are suprascapular nerve. Subscap are branches coming directly from the plexus, which is different to what the subscap is. And this is a dissection that I made, proposed arthroscopically, to show the innervation of the subscap and to show you how weak are the nerves of the subscap. And you can understand that if you manage, for example, a release, extra-articular release, and you push the release under the coracoid with your scissors, when you manage to do a shoulder arthroplasty and you cut all these nerves, you will have a fatty degeneration of your muscle. And you see how much these nerves are weak and small and going toward the muscle directly. This is the axillary nerve you can see here, and the plexus on the front. This is the conjunct tendon, and it's a right shoulder here. And here, where you see the plexus there, you can do this dissection, and you can even see the artery, which is right there. So that dissection shows the anatomy of the subscap, which is tremendously important to understand. But what you should notice is even the distance. The distance of the upper subscap here is very far from the plexus. So when you repair the upper subscap, you don't have to dissect the plexus. You only have to dissect the plexus when you have a massive subscap tear. And this is linked to the stability of the biceps. And here you perfectly see that you have a biceps instability, which is linked to a detachment of the deep layer of the subscap. Today, we have made a classification, as you kindly remind, that this is not linked to the biceps. And the biceps itself, it's very important to understand that the biceps is the first one that will show you that the subscap may be torn behind the ligament. And this is really something new. What do I mean? If you have an anterior biceps erosion, it means that when you have an integrity of the ligament, which is the superior glenohumeral ligament, you may think that the subscap is intact because the tear is eaten by the integrity of the ligament. And this is important that we underallowed this a few years ago. And what you can see here, for example, is it looks to be, this is another shoulder, so the other side, it looks to be an intact subscap. But you have a sentinel sign, which is an erosion of the biceps. And if you cut the superior glenohumeral ligament, what you will discover is here the subscap tear. Behind the ligament, you see the subscap is torn, and you see that this has led to an instability, partial instability of the bicep, which leads to an erosion of the anterior biceps, which is tremendously important. Now, what about a classification? Classification is very easy, but it's only about the total layers of the subscap, and we are working currently on making a better classification, an improvement of the classification with partial tear of subscap, 1A, 1B, 2A, 2B, 3A, 3B, 4A, and 4B. And this is type 1, 2, 3, and 4, where you can see that the subscap is torn more or less, but what you can see is that the head is still centered. In type 5, that we will not consider today because it's not about the subscap tear, the center of the humeral head is not here anymore, and there is an anterior superior escape, which leads to a coracoid impingement. So what is it? Why is it important to use this classification? Because if you have the upper third of the subscap, which is type 1 and 2, and then you can repair it from inside the joint, and we will say it. As soon as you start to have, excuse me, to have a bigger subscap tear, larger subscap tear like a 3, and then you may move from inside the joint to outside the joint. And at least if you have a massive, and then you must be extra-articular to release the plexus and to bring the tendon back to its normal place. So let's have a look first to this one, with the subscap tear at the upper third. This is certainly one of the most common. I must say that now I'm really paying attention not to over repair this subscap tear. It's important to notice where and to see where the deep layer is and to bring the deep layer back here. Very often these patients you operate on are stiff post-op and they have pain. And it's important to keep the rotator interval open post-op. But you see that here we can repair the tendon without trying to repair the capsule, or we can bring the capsule and the tendon back to his own place. It's very important not to over tight this. And here you see that we just bring the tendon back to his lesser tuberosity with 2 anchors. This is an old video with 2 metallic anchors, and we bring back here the tendon, and we should avoid to over tight this, because otherwise the patient will be very stiff and painful post-op. And it's even important to cut the biceps in these cases, because otherwise the biceps will be squeezed and will be responsible of the pain post-op. This is the kind of transition. How do we go from the subacromial space to the subcoracoid space? And this is exactly what I am showing here. We're on a subacromial space, and this is the anatomy. There is a fascia that separates the subacromial space to the subcoracoid space. And this is where you can find and follow the coracohumeral ligament, and this is where you can open the rotator interval. When you do this, there is a communication between the intra-articular, subacromial space, and subcoracoid space. The subcoracoid space is here, limited by the tendon, and you can even go outside the subcoracoid space, open the fascia to go to the subpectoralis space. And here you open and you make a communication between every space. And here you can enter and try to repair and insert your anchors. So what is it mandatory to expose the nerve? This is a slide, a very old slide, even Flateau many years ago at Val d'Isère, maybe 20 years ago, when he showed the release that I am doing now from the nerve, and everybody is scared for the nerve. But when do we have to go to the nerve and to release? That case is a typical case where you have to release. You have to release because you see that if you want to bring the subscap back, you can't, because the subscap is stuck to the medioglomerular ligament and is stuck to the coracoid process and is stuck to the conjoint tendon. This fascia is the fascia of the subcoracoid space. And if you look at this fascia, as long as you don't open this fascia, there is no danger for the plexus. As soon as you open the fascia, and then it's like you bring a curtain and you open a curtain, and then you will see the plexus. It's just behind. It's a different room. It's a different space. It's just a way to communicate. And it's very important in the shoulder now to know from which room you are treating which tendon, because a tendon is like a wall in the house of the shoulder. It's not the house with only one room. It's the house with several rooms. We are communicating, and you need to open windows between the room in order to restore the wall. And this is where we can restore the wall. And you see we have an access from the subcoracoid space, subacromial space, and intra-articular space. This is another example. Left shoulder, you can see here, this is a live surgery. Left shoulder, you can see that here we have a very thick anterior super rotator cuff tear with an instability of the biceps. Look at the frames that we see on these biceps here. And look at the adhesion of the subscap here. Between the subscap and the coracoid process and the subscap and the conjoint tendon. And look at this adhesion that we have here at the anterior shoulder on the subcoracoid space. So this is one of the most tricky surgery that I know, where you need to release, knowing that at some point you will see the plexus, and it's very hard to find the plexus without damaging the plexus. But if you try to bring the tendon back to its anatomic location, you see that here you can't do it because the release is not good enough. So I had to increase my release, and I had to do more release here toward the plexus in order to be sure that I will be able to bring the muscle and not only the tendon back to its anatomic position without pulling on the plexus. Means that I will not damage the nerve by pulling the tendon back here. So you need to release this. I'm initially a hand surgeon. I've been doing more than 1,000 plexus surgery open before I started to do arthroscopic surgery. So the nerve for me is not a problem. It's like he's like my friend. I never damage the nerve by doing this nerve release. This is another and last example that I want to show. Am I on time, Usama? Is that okay? Okay.
You're fine, Laurent. Okay, go ahead.
Okay. So this is another left shoulder, another example here, which is very similar to the previous one. It's just to show you that it's not so different cases. We have many different cases where very similar is when you have a massive retracted subscap here with a terrible pain, which you can see here that the patient, you know, they have pain on the hand, they have pain on the fingers, they have pain everywhere, and they really complain about this numbness here. So this is the anatomy, this is the conjoint tendon, this is the subscap, and you see here that the space is very narrow, and when you pull on the subscap, you can't do it. This is a very important trick, is to start the dissection of the subscap. This is why I wanted to keep this video different to the previous one, is that you need to find the coracoid process. The coracoid process is like my index finger. If you start from there, you will find the upper border of the subscap. And you will find this anterior ligament, which is a very important one, coracohumeral ligament. You release the coracohumeral ligament, and you keep the link between subscap and supraspinatus, which is a very important link. And you must keep that link every time in order to bring the tendon back to its place and to have a very secure fixation. Once you do that, you put the traction suture on it. And then you pull, and you manage to do your dissection again. So I do it with a vapor. I release still the same aponeurosis that you know, and you go from the inferior side of the subscap where you feel the axillary nerve to the upper border of the subscap that you hear. And progressively, you do your dissection, as you can see here. Progressively, you do your dissection, and you will find the plexus there. The first nerve, the most posterior nerve you will find, will be the axillary nerve. In the front of it, you will see the artery, and you will see the radial nerve. It's very hard to see the musculocutaneous nerve from that side because the musculocutaneous nerve is anterior to the shoulder. But here you see all the adhesions. And you see that the upper part of the subscap, there is no risk because the plexus is very medial here. It's difficult and more tricky, more inferiorly. But by chance, what you can see here is that you will see that the adhesion is easier to dissect as far as you go close to the plexus. And here you have your total dissection, and here you bring your probe very inferiorly, you respect the fibers of nerves who are going toward the muscle, and here you are going inferiorly in order to repair this subscap without pulling the plexus together with the subscap. I'm showing here cases which are not the most common cases of the subscap, but this is where, you know, sometimes you have to be, because the subscap retraction are leading for young people, very often traumatic cases, are leading to very high symptoms. And it's important to release everything in order to repair. And now once the release will be over, you will go back to here. I will go a little more for the video, and then you will see that here, this is at the end of the surgery, where you will see that we have passed every suture, and we bring every suture back to here, and we manage to make a double row repair of the subscap together with the supraspinatus down to here. And we do the double row repair, and you see that this is a watertight shoulder, but we keep the rotator interval open. It's very important. This is the patient. You see, it's not an old guy. He's a young guy. He's about 42 years old, and he had a massive tear. He's a laborer. He is working hard. And you see he has big muscles. He's 3 months post-op. You may say, oh, he's a little stiff. I don't care. For me, the stiffer the patient is at 3 months post-op, the stronger he will be at 2 years post-op. And I don't care about stiffness for subscap, because finally they will go to a very good result if you respect the healing process. And this guy is here, you see 3 months post-op, able to resist to the push of my fellow. What about post-care? No retropulsion. It's very important to understand, and I don't know if you have a vision to my video, but here it's very important that the subscap here is not going like this. And this is tremendously important, that you don't let the elbow going back to here, and that you keep the elbow on the front, because what is the worst scenario is that you keep the internal rotation, but you bring the elbow back to the thorax, and this is what pulls the most in the subscap. As I told you, we do immobilization for 6 weeks, internal rotation in case we have a majority of subscap tear rather than posterior superior tear, and no physiotherapy for close to 3 months, 6 weeks or 3 months. I let the patient do what they want to do, and I don't want them to go to physiotherapy before 3 months. After 3 months, the tendon is healed or not, retorn, but at least they can do whatever they want. So we publish things, and you know, this is not very interesting because you can see the publication here, and you know that we have good results, but what we can know is that we have a lot of type 3 and 4 in a massive subscap tear, and we published that we had a very good result despite the fact that we had a big subscap tear in this patient that we show, and we have here a very interesting thing, and to show that the biceps was pathologic in 93% of the cases, which is normal. And these are the results. We made a few pec minor transfer, and I didn't show you here the video, which is not the most important thing, but what you can see is that if you achieve to do a good subscap repair, you will have good results most of the cases. The re-repair rate is not that big, and it's related to age, fatty infiltration, and the dimension of the subscap tear, and the post-op. If the patient does not respect the immobilization and go back to activity before 3 months, it will for sure go to have a recurrence of calf tear. So it's important to see that there is no influence mostly on that very significantly, but there is an influence of the fatty infiltration because we don't have type 5 on this. So the conclusion is that we have good, excellent outcome, low retear, excellent return of strength, and no external rotation deficit if you release the plexus correctly. And if it's irreparable, and then we can talk about it, but this is another topic about how to manage an irreparable subscap tear for young, middle young, and old people. Old people is easy. reverse. Middle young is difficult. Young is more than difficult, but tendon transfer, mostly latissimus dorsi transfer, or pec minor or pec major transfer can be discussed for these patients. So there is no need for plexus release in this repair in type 1 and type 2, and most of the time for type 3. Plexus release is mandatory for type 3 and 4 for when you have adhesion and inflammation in order to avoid nerve complication and to increase the pulse. Thank you very much for your attention.
So, as we said here, thank you for this. I think the best thing is to go over these cases as Laurent did. So, but the most important when we deal with the massive tear, it's a big tear. It's more than one tendon, more than 5 centimeters. It's a difficult one. So when you deal with them, you have to understand that these are less predictable and usually associated with higher rate tear. So meticulous attention to these cases to minimize the failure rate and to improve the success to do with the many factors like increase of fatty filtration. You have to review the MRI. You have to see whether the patient is smoking. You need to get the size of the tear and the complexity of the tear. And the tricks here, you have to make sure that you have a very capsular release because that sometimes can prevent you from reducing the tendon back to its place. You have to see that you're taking the full thickness, because sometimes you can get fooled by having only the superficial layer. Sometimes you need to medialize the medial anchors to shorten the distance for the cuff to repair. Tricks like marginal convergence for longitudinal split, and other augment like the biceps patch and augmentation with the tissue. So if we're gonna look at this patient, which we will see here, this gentleman is 55 years old. This is intra in the joint, in the glenohumeral joint. You can see that there is a V-shaped tear, but even the deep layer is 2 layers, 1 layer and the superficial layer. So when you want to repair, you have to address this. Then you have to see it's like a more of a crescent shape. You have to see if it's reducible or not. Because if you try to repair under tension, it will not come. You can see now it's a slip back. So you need to do the release from around the tendon. You have to go on the top of the tendon and release it adequately. And as well as you have to go between underneath the tendon and take especially the capsule or the scar tissue that formed between the superior glenoid or the labrum and the cuff itself. So we have adequate release here to start with. So we can see it is coming more. Now we're going with the shaver underneath and the top of the labrum, the biceps, to release that scar tissue that formed from the tear itself, as well as from the capsule, the inside. And once you get enough release, you can usually mobilize this tendon properly. I usually prepare the foot area to shave it so we can get good bleeding. We put first anchor. If you look here, this is the double thickness, the foot thickness of the cuff, the superficial and the deeper layer. So we have to go through that. I'm using the tension suture to bring the cuff to me so I can handle it and I can pass the suture through the cuff. This is the anterior medial anchor. And here I switch to the glenohumeral scope from inside just to make sure that I don't take the biceps tendon with me when I try to repair, and I have to take the full thickness here. I usually use a lasso, suture lasso to pass the suture exactly what I want. And after we pass, we tie it medially, and this is the lateral anchor here So just a routine. And you can see here, we did this cuff repair in full. And this is, we did this gentleman in November. And this is him now, 5.5 months after the repair. You can see almost full range of motion for that massive tear. And he's extremely happy with his range of motion. So although massive tear can be difficult to address, but if you meticulously address them properly, you can get them where you want and where the patient wants. So we'll go to the next. So this is another lady. She's a 73 years old, 6 months of bilateral shoulder pain. On the right side, she has almost done fatty degeneration. She needs a reverse. But on the left side, it was relatively newer when she present. So we discussed with the patient that we will tackle the new one. At least we can repair it, and we can do the reverse anytime later for the right side. And we did actually a couple of weeks prior to Corona lockdown. So I'm following with her. So when we talk about marginal convergence, it's a trick that we can use in our armamentarium, especially if you have an longitudinal tear that require approximation to get a proper repair. It's difficult and different than the previous one with the C-shaped tear. So this is the lady. We had this tear, which I'm preparing the footprint here. With the women, there's osteoporotic, so I try to be gentle with the cortication of the footprint area. We're looking from the subacromial space. This is the tear. You can see it's a split. It's tight. We cannot bring it to where we want. So we went with the first anchor. And again, you can see this from inside. I'm looking at it, just making the two anchors in the medial, and you can see it's a longitudinal split of the cuff. So here I went back to the glenohumeral scope. I usually like to switch in and out, especially for the anterior part of the cuff. I want to make sure that I'm not catching my biceps tendon, and I have a good thickness of the cuff. And here I'm just releasing the scars between the superior labrum and the glenoid and the cuff to make sure that I can mobilize this cuff when I repair it properly. Then I use, again, as I said, I use a lasso for my passage. I pass the suture for both anterior and posterior. Then I went, after I finished the two suture pass through both anterior and posterior, then I insert my marginal convergence suture using, again, lasso. I pass it this front, then I go from the back. And then it's a suture management. You have to know where you put your suture and how you balance. And you can see down there the loop of the orthocord. And then I repair them. I tie the suture here. In a second. Usually this trick can bring the tendon where you want it, and it can help you with the major repair. It's a nice trick to repair longitudinal split. So after we put that one, I insert two more, one anterior suture, this one for the anterior part of the cuff. And I thought I didn't like the look in the back like a dog ear, so I put one to close it and to push it inside. Then I used the suture part from the anchor, and I and tie them both together like a double poly repair. See, I tie them together, and then this is the knot. Then I get the two other part, and I tie them in the front. Then I take the tape that's in both anchor and fix the lateral row with a knotless anchor. You will see now. With the old ladies, I always worried about their bone quality. That's what the posterior lateral row, and this is the anterior lateral row. I use something like Spuffer lock here. And you will see now the repair. I usually switch my camera to the front anterior portal to look at the repair itself fully and make sure that the construct is what I want and there's nothing missing before we close. And with this way, we have a very good repair. She's now, this lady, peculiar, she's now 2 months since her. So that's for the superior posterior repair. And I was talking yesterday to Laurent, and this is a very interesting case. This guy is a 40 years old male who fell from stairs. I don't know how he put his hand, but he get a shoulder dislocation. And if you look here, there is a massive tear in the infraspinatus as well, and not just a pure dislocation. And you look at the MRI here. This is the axial view. This is you can see there is a tear on the supraspinatus as well. And this is his MRI. You can see how the extent of the tear goes through the infraspinatus. So we have to, when we need to manage this patient, we have to address all his problem. He has a traumatic tear. He presented to me 5 weeks after his injury, so it's not acute injury. And so he was in pain, he couldn't sleep, and we diagnosed him immediately, and we planned his surgery, age and young and active. So when we went with the scope inside, it's different than everything. It's a Bessay capsule is like when you go from the back, you look at the shoulder, you don't see that big room here at the back. This is definitely not what we see every day. It's a pitulous Bessay capsule due to the redundancy of the infraspinatus and the capsule and the tear. He also has anterior labral tear, but for the sake of the presentation, we're not going to go through that for now. We just focus on his anterior laxity from the infraspinatus tear. This is from we went to the scope from the front to see the capsule and how redundant is the capsule. So we went ahead with the repair. Here we identified the tear through the rent here. So we try to minimize the dissection. There's a lot of scar tissue and from the previous, from the injury itself. So we try to be gentle here with the soft tissue. We went down to the bone and we prepared 2 anchors for the infraspinatus part. And we use double row fixation again for this. I usually like to put anchors that has both suture and tape because I can tie, and I use the tape to support the repair. And you always have to manage where you put your suture, not to mix it up. And you have to know where exactly you're putting your other suture. So suture management is essential when you deal with this repair. I usually don't use cannulas for my arthroscopy. I think I owe Laurent for that. I visited him in 2006, and that changed what I do, and I stopped using cannulas. So this is, we tie the knots anteriorly, and we tie the second knot, the second anchor in the same fashion. Then we fix it laterally. He has a good bone quality, young guy, so we use something like a butch lock station. I wasn't worried about his bone quality. He's only 40 years old. So the moment we fix the infraspinatus here, you will see in a minute the second anchor. The difficulty with infraspinatus, you work under your scope, under where you stop. So it is not like when you do the anterior part, you look forward. This is always in your armpit, as they say. So you can see this is, we have a good repair. We tested the muscle, we push, and you see how our repair, how is it. And we just went ahead and deprived. And the next step was to fix the anterior part of the cuff. You can see that the tear and the supraspinatus, and it was very clear now once we repaired it at the back. And we did the same when we did double row fixation as well. As you see, this is a young guy, double row. We need to minimize any risk of re-tear, especially with this massive. So we put an anchor there and repair it there. We find there's a flap in the middle, so we add one more tape to close that. We use tape to close this one, to close the middle. So this is the overall repair. And this is how the capsule inside look like afterward. And so this is, if you look at the capsule, this is initial, and you can see That's how it's redundant and loose, butulus and book, and then and this is bust up. You can see it's all closed, straight. The muscle is tense. We're trying to find a space to get to see properly. It was difficult, not like at the start. And this is the gentleman at 4 months following his repair. He still has little bit limitation at the terminal end, and this is his abduction. Internal rotation. And this is his external rotation, which is 4 plus at this point. We need still to strengthen it, but it's very good for him. Laurent was talking about large subscapularis tear, which is not the very common. The very common is the grade 1 or 2. So I'm going to show you what I do for grade 1 and 2. I can see here, this is freeing, and so we need to debride it. Of course, you have to debride between front and the back of the subscapularis. So otherwise, you cannot free it. You cannot mobilize it. Here, I didn't need to free a lot because it's already still, the length is intact, but you have to bring this up. You have to pull it up to you. So I debride, you can see here, it's almost peel off the lesser tuberosity. So usually shave it and prepare it. My repair, I use a lasso here. I put double figure of 8 suture, so we pass first time. Then we pass the first suture, then we pass the second one. When I pass the second one, I have to manage the suture to go over the proper tissue. You see, if you look at medially here, that's a good tissue here of the subscapular. So I've tried to tease the suture loop to go over the good bulk of the stuff, otherwise it will not bring it forward for the repair. And then I pass another one to give it a double repair. And I usually fix it with the knotless anchor. And this is the second anchor anteriorly. Usually not worried about them. They usually do very well. You can see the tissue is good. So, and I can see the repair, they always do very well. At the end, I want to show this picture, me and Laurent from November 30th, this is 2nd of December, our National Day in 2006 in Annecy. Me and Dr. Ali Suwaidi, Dr. Hussein Al-Matri, Dr. Amr Mansour, and Dr. Ahmed Sayyad. And of course, Professor Laurent Lafosse was the star of the show. Thank you.
So my disclosure, I will start with something which is very important because, you know, Saeed showed you many important things and tricks, and I love this video, mostly the video of the release, and we both spend a lot of time to release. And I think that, I don't know, we will discuss with Saeed, but I think that most of the surgeries, 80% of the time is release and 20% of the time is repair.
Yeah.
And I think it's very important to not to rush to the repair, but to expose the shoulder and everything. And sometimes this is even a very important key point that I want to underline is that we neglected a lot of cuff tear and a deep layer tear due to the fact that everybody is starting to do the shoulder arthroscopy from the back. Now in every massive rotator cuff tear, I do my shoulder arthroscopy from lateral, and I start from the subdorsal view. And if you do that, and then you will see what happened here is a double layer repair. So let's go to this double layer and the bird pick. We have here the anatomy of a normal patient here, which is the bird pick patient. And this is Usama. Again, we have many microphones working on. I don't know if you can do something. So it's important to know that there is a differentiation between the deep layer and the superficial layer. And here the superficial layer will be involved in more abduction after 60 degrees at the deep layer. And the tip progression is always from the deep to the superficial layer for a double layer tear. And sometimes the opposite, which means that the deep layer can be intact and you have a superficial layer tear, mostly when you have a big AC joint arthritis and impingement. So there's a kind of combination, but it's very important to understand that you really have a t-shirt and a jacket on the top of the t-shirt, which is the deep layer and the superficial layer, with a very thick deep layer and sometimes less thick superficial layer. So the question is how to do that. We can do the double repair to repair both layers together, or we can do it differently. And what I don't really like is to bring these two layers, avoiding to respect the anatomy. So what I want to do is to respect this deep layer fixation with the superficial layer fixation differently. This is how I developed the lasso loop technique. And this is what I want to show you on the case. We don't do so many MRI, we do CT, but what you can see here is that it's a massive cuff tear. And that we will see the perioperative video. So this is a double layer cuff repair. And you see here, deep layer is there. This is not a capsule. This is the deep layer of the rotator cuff, because you can see that. And this is the superficial layer of the rotator cuff, which is a different layer. And that comes at a different level, because the deep layer stops its insertion at the level of the cartilage. The superficial layer is inserted toward the lateral side of the great tuberosity. So as they have both a different insertion location, you should restore the anatomy by doing a different repair for both layers. So what I want to do is that I want to repair the deep layer first with this lasso loop technique here. And you see that this deep layer has been repaired with the lasso. And you will see that I'm using the two threads of the anchor differently. This anchor has two sutures, and each suture has two threads of force. So I use one of the two threads to manage the lasso of both sutures, the blue and the white. Then I pull on the other one, like on a pulley. And I bring the deep layer back to its location here. What about a superficial layer? I use the same suture, same thread. But here I restore it at a different level because I restore the anatomy this way. And you see here that we restore with the deep level here, the superficial layer, by going through the superficial layer to capture the suture which has been used to manage the lasso loop of the deep layer. So now we have one thread of both sutures which has been passed on this manner. And now we will have the two other threads of the two sutures are going through both layers now. So it's this management of suture is maybe a little complicated to understand at the first shot, but it's not very difficult to understand. And the main advantage is best is that it will restore the anatomy, exact anatomy. And then you can use 1, 2, 3 anchors medially to restore the reattachment of the deep layer with the lasso and to go with a mattress through the superficial layer. And this is what I'm doing here. And what you can see is that sometimes in order to be faster, you can go through the loop, but this is more technical trick to go faster, to catch the suture inside the loop and to manage on one stage instead of two stage the suture. But what is important to understand is that when you will pull the knot, the post will be the thread that goes to the anchor without the lasso. Means that you will pull on that post in order to bring the lasso to the anchor and to use the anchor as a pulley. And you see that we restore really the anatomy. And it's not only to restore the coverage of the tuberosity, but it's something that will really restore the entire anatomic insertion of the rotator cuff. And as it was perfectly shown by Saeed before, and then we do the suture bridge with a knotless anchor, whatever anchor you want to prefer to use. But what is important is that this bone is very soft, and this is why I want to tie the knot medially and not to keep all the suture in my repair on a knotless anchor without tying any knot for the medial row. So that's the repair. We have an experience. We published this in 2018, sorry. So 2 years ago, and we have a significant improvement for 82 patients. And we saw that there is a lower pain score in patients when they went separate double layer repair and a strong, very, very strong repair. So now, if you allow me, I go to a massive cuff, or we can stop here, Usama. It's according what you prefer in terms of timing.
How long it might take?
10 minutes.
Go ahead.
Eight. Okay. So massive cuff tear. That's the schematic, the size, the number, the repairability. I would say these two last steps are the most important. Size. Sometimes you have a big tear, easy to repair, and you think that you are a very good surgeon. And the next patient is a small tear, you think you will be very fast, and it takes long and hard to repair. So the size of the tear is not always a criteria which correlate directly with difficulty. So what is for sure is that repairability is something when you can't do that, and then you need to find something else. But let's look at the repairability and the case presentation for a young guy, hairdresser. Here you see the X-ray, you see it's a large cuff tear. I will go fast to this. And it's a massive cuff tear repairable because of age arthritis, minimum superior escape, good subscap, no fatty infiltration, which is a very important criteria for me. So let's go to this. This is the tear, and this is the size of the tear. See, it's not a small one. I start, as I told you, from lateral view. The biceps is involved, supraspinatus is involved, subscap is intact, but the biceps here is involved. So I think it's important to understand how to manage this. The first thing is to clean. And now you do everywhere, you clean and you release the cuff. And that was a wonderful video from Saeed before to show you the release. And this is the extraarticular release. So let me show you the extraarticular release here. So this is the extraarticular release where you can see that it's bleeding. One of the problems sometimes is that as you want to see well, you create a lot of swelling with the shaver because you want to see, so you increase the pressure and it's bleeding, and then you have swelling. This is not good. You must pay attention not to over tight the shoulder, to be fast on that stage, and not to increase too much the pressure of the shoulder, and in order not to have too much swelling. I do love to open here the joint under the cricoid process in order to release very well anteriorly and to see if it's cricohumeral ligament, It's the right shoulder, we come from lateral, and here we can see that this cricohumeral ligament is really attached to the cricoid and we want to detach it. We want to do an intra-articular release, and here it's exactly what has been shown by Saeed before. You do it anteriorly, you do it posteriorly, you do it superiorly. Suprascapular nerve release, which is a very interesting discussion, but I can tell you, but what I know is that I don't know when to do it or when not to do it. But what I do, every time I have a master rotator cuff, I go to the nerve, I look at if it's squeezed. If it's squeezed, I release it. If it's not squeezed, I let it go, and I don't touch it. But I look at the suprascapular nerve, it takes for me 30 seconds to 1 minute to do the release, and it's not a very difficult thing, and sometimes it helps a lot for the post-operative pain, to have less pain for the patient, and to get a better reconstruction. The medial row, this is a combination, and that was one of the questions before. Do you prefer with subscap to do a biceps tenotomy or biceps tenodesis? I do usually biceps tenotomy, but if I want to use the biceps to reinforce my rotator cuff repair, and then this is what I do. I do a biceps tenodesis that combine the biceps fixation to the anchor and the anterior footprint of the supraspinatus together on the same anchor and the same suture. So I do my single or my double lasso loop around the biceps, and then I pass this thread around the tendon of the supraspinatus in order to have something that will combine both tendons together on the same anchor and the same suture. That allows me to reinforce the anterior footprint of supraspinatus. And of course, I cut the biceps from the glenoid in order to have a biceps continuity together with supraspinatus, which is exactly the opposite to the what is the very well used today superior rotator cuff reconstruction with the superior capsule reconstruction. Yeah, just detach it. And then we have the posterior one, and then I will do the same repair as what we saw before. So I will go fast on this, and I will do a double row repair with a double layer, so I will escape this one. One of the tricks I want to show you is this one. When you don't see very well, and this is one of the other questions, do you prefer lateral decubitus or B-chair? I use B-chair with some traction anteriorly, but the side effect of B-chair is that sometimes you don't have a lot of room posteriorly. And in order to have room between the bicep, between the deltoid and the infraspinatus, I just insert the Foley catheter that urologists are using. And if you dissect the nerve, which is the axillary nerve laterally here, and then you can see that this is where you see the nerve, and it's not dangerous for the nerve. So I will do my double row repair like I showed you before, which is fine. And then I will use the suture bridge as I saw before, which is okay. Acromioplasty, and I will do. And now, what about some people who has a non-repairable? This is a non-repairable. That will be my last video that will take 2.5 minutes. This is a lady that I know. She's a surgeon, and she has a terrible pain due to a problem, and I repair her, and I had to use a side-to-side sewing machine. What is it? It's this. It's exactly what you use every day with a sewing machine. I started to do surgery when I was 4 years old. My sewing, I loved to sew when I was a child. And I'm still sewing, and I haven't forgot what I was learning when I was a child. The sewing machine is nice. It works like this. So let's look at this video. This is a massive tear, and it's like what Saeed showed you before. It's a side-to-side, but without anchor. So this is the anterior layer. It's a V shape, and very often you have a V shape, and you can even have a double layer here. But you see the quality of the tendon does not allow you to come back to the tuberosity and to make it work. So what I did is that I took one suture, only one. It must be a good suture, because if you take a bad suture, it's not going to work well. But here you see, you take both layers. This is the deep layer, and I will manage to make a lesser loop on the deep layer here. Is that okay, Usama, if we run this video 2 minutes more?
Yes, yes, you can.
Okay, and then my lecture will be done. So this is the deep layer, and I do a lasso. As you can see, I use my two hands. My assistant, my fellow, is holding the video. He's my brain. My fellow is my brain. I'm only the two hands. But I have one hand on the left, one hand on the right, with a clever hook on the left and a clever hook on the right, or a suture grasper. So here I have one of the suture, and I used my clever hook from the left to prepare and to expose my rotator cuff in order to grab the suture with my clever hook on the right. And that's the start of my side-to-side suture. And then progressively, I will create a loop. The loop comes from the right, which is the front of the shoulder. And I will go with this loop toward the left, and I will bring it toward the posterior layer on the left. And look, this loop, I will take the suture which is on the back and go through the loop with the suture on the back. And this is the running suture. You see 1, 2, 3 loops, 1, 2, 3 loops coming from the front, and the running suture which is straight going through each loop on the back. And when you have these 3 loops here and the suture, and then you will pull on both sutures, and progressively, what is interesting is that the side-to-side will automatically be balanced as a permanent traction, which is a balanced traction from medial to lateral, avoiding to have an excessive traction, lateral or different traction from the lateral one to the third one. That's it. And this is how to close the suture. So in conclusion, the repairability is not always linked to the size of the tear. The muscle statement is certainly the most important parameter. Release and analyze of the tear before repair is the most important step, and very difficult to manage without swelling and excessive swelling. You must be very frank with your anesthesiologist in order to have good condition for repair. Thank you for your attention.